We are live now. With all your permission, I'm starting this webinar for today. Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. I would like to invite today's speaker with great honor, none other than Dr. Siddhi Dinesh Prabhu ma'am, and she has done BDS, MDS, and conservative dentistry, endodontist, cosmetic, aesthetic dentist at Shrudan Dental Clinic, Mumbai. And today she is going to speak on a very important topic, that is immediate intervention for serve endodontic on the occasion of National Toothache Day. So by taking not much time, I would like to invite ma'am and hand over this session to ma'am. Ma'am, over to you, ma'am. You can proceed from here.
Thank you so much, Faraz. Sorry to say you that my name is Dr. Shashilekha Govind, and I'll be talking on the topic dental abscess demystified. So basically, I'm from Odisha. Evil being the root of mystery, pain is the root of knowledge. With this, today's content of my topic being introduction to my pulp and periapical, and these are the few contents, headings, which I'll be discussing in future. So coming to the introduction to pulp and periapical region, the dental pulp, it is a soft tissue which consists of mesenchymal, which is a mesenchymal origin located in the center of the tooth. So basically, it consists of a specialized cells and odontoblast arranged peripherally, and also it contains peripherally in the direct contact with the dentine matrix, which we call it as pulp dentine complex. It is the principal source of pain in the oral cavity. So it acts as a major site for all the restorative and endodontic fraternity. So as you can see here, for picture number 1 and 2, you can see the pulp with various anatomy, and it has a vague volume. The volume depends on various tooth structure being smallest, that is the volume being smallest in the lower central incisor and being the biggest volume in the maxillary molars. So when it comes to periapical anatomy, it basically consists of cementum, alveolar bone, and the periodontal structure. As you see in the picture here in the X-rays, where you can see the root and the root which has basically the root dentine, followed by cementum, periodontal ligament, lamina dura, and the apical foramen. So coming to the etiology of the periradicular diseases, the common etiology being the dental caries, then accidental exposure, percolation around a restoration, extension of infection from gingival sulcus, periodontal pocket, and the abscess and anachrosis. Anachrosis is nothing but the infection which spreads to the blood vessels or to the bloodstream. Then the next most common is the trauma. The acute trauma like fracture, luxation, and avulsion. The next common will be the bruxism or trauma from occlusion. The iatrogenic thermal changes during tooth preparation, orthodontic treatment, periodontal curettage, periapical curettage. The idiopathic being aging. So as ages, the circulation also reduces. Then comes the resorption, and which is internal and the external resorption. These are the few clinical pictures showing that there is the caries causing the periapical lesion and the gingival abscess due to the calculus and other factors. And here the picture 3 shows the periodontal abscess involving the tooth, and the picture 4 shows where there is abscess due to the dental caries, which is a non-vital tooth. Coming to the classification of the periradicular pathologies, the basic day-to-day or in our clinical practice, we see symptomatic periradicular diseases like acute alveolar abscess or Phoenix abscess. Next being most common is asymptomatic periradicular disease like radicular cyst, condensing osteitis, and chronic alveolar abscess. Next being common is external root resorption or the persistent apical periodontitis. So coming to what is dental abscess means, it is a dentoalveolar abscess or the tooth abscess or the root which is the root abscess is a localized collection of pus as a result of a bacterial infection associated with the tooth. Here it presents as an excluding infection involving the root of the tooth or between the gums and the tooth. Let's know the types of dental abscess. So one is the periapical abscess. We are showing the collection of pus at the tip of the root. Gingival abscess, which is localized collection of pus, which involves the gingival tissue. Periodontal abscess, which is localized collection of pus involving bone adjacent to the tooth. Then pericoronal abscess, which is mostly involved in the unerupted or erupted third molar region, where the gingiva enveloping will be inflamed. Then combined periodontal and endodontic abscess, where culmination of periodontal and the endodontic pathologies, as shown in the picture 5. So these are the clinical pictures showing the abscess formation due to dentoalveolar infection. So here, this is an extraoral pus discharge, and here the picture 2 shows the intraoral abscess formation or the pus discharge. Coming to the pathogenesis of the periapical lesion. So when there is a normal pulp, where the caries or due to trauma, it undergoes acute pulpitis or the chronic pulpitis. If it is left untreated, it undergoes pulpal necrosis, which in turn causes the periapical inflammation, which due to non-vital pulp and the necrotic tissue. So if it is left untreated, then due to pro-inflammatory mediators will activate, and that will form the periapical granuloma. Again, if granuloma is not treated on time, it can lead to periapical abscess. In turn, it can go to sinus tract. And if it is due to the host response and based on the condition, which type of mediators are involved, it can lead to periapical cyst. Let us jump into what exactly the periapical abscess means. So these are the various synonyms for that. And it is basically the inflammatory reaction of the pulp infection and necrosis characterized by rapid onset pus formation, spontaneous pain, tender on percussion, and eventually swelling of the associated tissue. Let's know the pathophysiology of periapical abscess formation. So basically, there is an increase in pulpal circulatory pressure, then collapse of the venous circulation, hypoxia and anoxia of the local tissue, localized destruction of the pulp tissue, formation of apical abscess due to breakdown of PMNS bacteria and lysis of pulpal remnants. So let's know what are the symptoms, clinical symptoms, or the patient come with what type of symptoms. In early stages, there is tenderness of tooth, which is relieved by continued slight pressure on extruded tooth to push it back into the alveolus. Later, the patient experiences throbbing pain due to development of diffuse swelling of overlying tissue. The tooth becomes more painful, elongated, and mobile as infection increases in later stage. The patient usually presents with fever and increased WBC count on blood CBC report. In clinical presentation, we can see if there is a swelling or if there is a sinus tract. The sinus tract can be an active sinus tract and a passive sinus tract. What does it mean? Active means if there is a pus discharge, consistent pus discharge is there on applying pressure, or that when you are going to do a tender on percussion, so definitely the patient can't bear even your digital pressure. So that means that it is an active pus or active sinus. If there is a passive in the sense, it oftenly comes and it is healed. So it forms like a fistula. So the patient will be usually asymptomatic in such cases, and where you cannot trace the sinus tract. So that becomes a passive sinus. So how we are going to diagnose the such abscess? So on clinical examination, in the initial stages, locating the tooth will be difficult due to diffuse pain. Now, if you have a frank caries, if there is an open and frank caries, then it's easier for us to identify from which tooth the pain is there or which tooth the swelling is there. But if there is no frank caries, and the entire tooth is intact. So in such cases, it might be due to the trauma or trauma from occlusion, or it can be TFO or any kind of non-vital. Over a period of time, untreated tooth also will cause the will present you the same clinical scenario. So in such cases, the most important is the vitality of the tooth and tenderon percussion, palpation, and of course the x-rays. Now, when it comes to pulp sensitivity test or the vitality test, usually you will have a negative response. But when it comes to a palpation or the percussion, you should be very sensitive when you are doing palpation or the percussion. So palpation is usually done with a digital finger, especially your index finger, just pass on to the area where exactly the patient is feeling tender. You need to ask the patient, and patient definitely he will present you which particular area is tender. Then after that, first and foremost, we have to be very careful that first we will do a normal area or normal arch, and then we will do the arch which we need to test, or the tooth which we need to test. And the percussion, first, when it comes to percussion, you shouldn't jump to using a blunt end of the mouth mirror or any kind of instrument. You have to do first the digital pressure is most important. So with your index finger, just point out or just press all the teeth and identify which teeth is more tender. So based on after that only we have to use our instrument. So that's how you have to do. Then when it comes to X-ray, obviously, if there is a chronic kind of abscess, definitely you will have a periapical radiolucency showing. But when it is a acute symptomatic periapical abscess, sometimes you won't have a significant radiolucency around the root. Only the caries extension will be there. That's it. So in such cases, but there is a frank caries will be there. So in such cases, we need to do the root canal treatment. If there is any kind of sinus tract, so you can trace the sinus tract to know which particular root or tooth is involved. So this is just a clinical photos showing how to do the sinus tract tracing. So here just at 1 and 2 is where there is a pus discharge. So if this is a chronic periapical abscess. It's a root canal treated tooth, which we can see here. There is a frank opening. So I just placed a gada percha to know which particular root is involved. So this is how you can trace the infection. Now, what is the difference between an acute periapical abscess and a chronic periapical abscess? In acute periapical abscess, it will be sudden and rapid onset, whereas in chronic, it will be gradual onset with time. So in acute, you will have a severe pain and often throbbing and localized, whereas here it will be a minimal or no pain, but sinus tract will be present. In the acute, you will have localized swelling, whereas here mild to no swelling. In acute, radiolucency may be present or poorly defined initially, but in chronic, you will have well-defined radiolucency. Acute usually will be associated with fever, malaise, and lymphadenopathy, whereas here, rarely you will have the systemic disease signs. So this is a chronic, what do you mean by chronic alveolar abscess? So it's a long-standing low-grade infection of periradicular bone, characterized the presence of an abscess draining through sinus tract. The synonyms you can see here that it is also called as chronic suppurative apical periodontitis or suppurative periradicular periodontitis. So generally it is asymptomatic, detected either by presence of sinus tract or on routine radiograph. In case of open carious activity, drainage through root canal sinus tract prevents swelling or exacerbation of the lesion. So how will you diagnose this? So when it comes to diagnosis, the chronic apical abscess, it's suddenly it's associated with asymptomatic, and patient will have a history of sudden sharp pain which subside and has recurred. On clinical examination, it shows large carious exposure, and vitality test usually it will be negative, and you will have you have a radiographic. The site of origin is diagnosed by radiograph after insertion of gutta percha and sinus tract, as I showed in previous slides. Then when it comes to radiographic examination, it shows diffuse area of rarefaction. So when it comes to treatment plan, so we need to do a root canal treatment which can establish the drainage and removes the pressure if there is any pressure. If there is a sinus tract, definitely there won't be any pressure associated. So basically you are going to remove the entire necrotic pulpal tissue from the root canal, and then you are going to make sure that you have a clear path and use a lot of irrigating solutions like your chlorhexidine is one of the most important since it is a good antimicrobial property it has. So you have to use copious amount of chlorhexidine irrigating solution. So if there is a draining sinus is active, as I said, it is if it is a pus discharge sinus, then it is called as active sinus, and usually you have a reddish pink color mucosa. Healed sinus shows absence of pus discharge and normal colored mucosa. So as you see here in this radiograph, you can see there is a huge lesion. Okay, here the patient complained of the discolored teeth. So on radiograph, you can see there is a huge lesion. So we had to just open up the and you can see here there is a palatal swelling. So the patient came with the chief complaint that there is a discolored tooth, as well as often sometimes she noticed the palatal swelling. So on access opening, you can see here there is a pus discharge. So just I would like to show the video how the pus discharge is happening on compressing the in the initial access opening only. You can see there is a lot of pus discharge, and as well as when we press the palatal swelling, there is huge pressure of pus is released. So in this way, if you do within 2 sittings, probably the entire pus drainage will be stopped, and you can go ahead with your regular root canal treatment by giving interval of calcium hydroxide and chlorhexidine combination intracanal medicament. Okay, then what is Phoenix abscess? Phoenix abscess is acute, it's defined as an acute inflammatory reaction. It is an acute exacerbation of a chronic condition. So where there is asymptomatic apical periodontitis, if it is there, suddenly it bursts out and it gives a huge, the patient will experience a severe type of pain. So that is called as Phoenix abscess. Clinically, often it is indistinguishable from acute apical abscess. There is sudden onset, tenderness of the tooth, and extrusion of the tooth from the socket. So on palpating, you have tenderness of the apical soft tissue. So here, so what will be how you are going to diagnose the Phoenix abscess? It's mostly associated with initiation of the root canal treatment, and usually the pulp test shows negative. Then radiograph shows large area of radiolucency in the apex created by inflammatory connective tissue which has replaced bone at the root apex. So how are you going to do the treat this case? So you have to make sure we are established drainage of the abscess to the incision. If it is both, if it is intraoral or extraoral, whatever the swelling is, basically we need to drain the abscess. Then following the subsiding of the symptoms, we have to do the root canal treatment. So this is a picture. Picture 1 shows there is a swelling here. It is associated with the root canal treated tooth. There is a fractured instrument here. Due to that, there was a huge lesion here. So this was treated with a regular root canal treatment, followed by a regular interval of intracanal medicaments. So when it comes to treatment modalities, here I'll be discussing based on the presence of swelling. So let us know, like, if there is a periapical abscess with intraoral swelling only. So how are you going to treat that case? So how are you going to diagnose it? So let us discuss in detail regarding that. So now when it comes to diagnosis, so usually on intraoral examination, we see that there might be there will be intraoral swelling with respect to the tooth involved. Now the tooth involved may be a carious tooth, or that has to be confirmed by using radiographs. And then if there is a sinus present, then as I showed you in the previous slides, we can do the tracing of the sinus. That is usually done with the gada percha to know exactly where is the cause for the infection. So how we are going to treat? Now we need to treat two different things. The teeth as a whole we have to treat, as well as the swelling part also need to be treated. So here regular root canal treatment, that is access opening, is done, and then you have to clean the entire canal and use copious amount of your saline and the chlorhexidine. Yes, hypochlorite is of a smaller concentration you need to use, but not so copiously like how we use saline and the chlorhexidine. In the end, you can use 17% of EDTA. This is in the first sitting. I'm not talking about the obturation part and all. This is in the first sitting. As soon as you have come across such case, so you have to initiate the root canal treatment and follow this protocol. Finally, you have to irrigate with the chlorhexidine. And also, now how are you going to treat the swelling aspect? Now the swelling aspect, that is what here, the negative pressure syringe. I'll show you in my subsequent slides. I have made a video how to do the negative pressure syringe. From that, you can remove the pus, and then if you are not able to remove the pus through the syringe, you need to give a stab incision around wherever the dependent area of the swelling. There you have to give a stab incision and then compress well so that all the pus is removed. So now, how are you going to decide whether I have to give a open dressing or whether I have to give a closed dressing? Now, when you have to give is when there is a active canal draining. Okay, when the pus is actively draining through the canal, then probably you have to give an open dressing so that you are not going to block the pus outcome. And then if it is inactive, when there is no pus discharge through the canal, only the swelling is there. So you can give as well, you can irrigate very well with the chlorhexidine, followed by just a cotton pellet is placed, and then give a thin layer of temporary. Now, why we have to give is the fluid lodgement should not go into the cavity and cause again infection. So to prevent that, you have to give a loosely bounded cotton and thin layer of temporary. When it comes to swelling part, the swelling part need to be treated. You can't leave it like that. If you want a faster healing, you have to treat the intraoral swelling. That's what you have to see, what type of swelling it is. If it has become a hard swelling, because sometimes the patient comes with a hard swelling, it means that they would have taken a lot of antibiotics and that forms a anti-bioma. So in such cases, you can't do any stab incision or negative pressure syringe you can't use. So in such cases, just you have to leave like that only. Just irrigate well with the calcium, this one chlorhexidine, and locally you have to follow. Whereas when you have a fluctuant intraoral swelling, wherever the dependent area is there, you can use your negative pressure or stab incision. In later appointments, you have to give the intracanal medicament like calcium hydroxide plus chlorhexidine combination to have an effective antimicrobial property. But in the first sitting, you shouldn't give because since there is an active drainage. So for subsequent appointments, you can give the intracanal medicaments. Now let us go to the role of incision and drainage in management of the dental abscess. So that's what, if there is intraoral swelling, how to give the incision and drainage. So what is the main basic purpose of this is to relieve the pressure. So for that, wherever the dependent area means that area will look very shiny and very thin. The epithelium will be very thin in that area. So in that area, you need to give a stab incision, or with a negative pressure syringe, you can remove the pus. So by doing that, you are going to prevent the spread of infection, and also it facilitates the healing. So that's the main purpose of doing incision. Then comes your indications for your incisions. So when there is a severe pain and the swelling, then fluctuant abscess, then failure of conservative treatment. So in those cases, you have to give the incisions. Then after that, you have to follow up. You need to give antibiotic, that is a broad spectrum antibiotics you have to give, followed by analgesics, as well as you have to give a chlorhexidine mouthwash. So the best chlorhexidine based mouthwashes, I'm not going to promote any of the brand, but out of my experience, I'm saying the PerioGuard is the best for in such cases. The PerioGuard mouthwash it works wonderful. So now, basically, what are the steps? How are you going to do the incision and drainage? So once you have seen clinically, okay, there is a fluctuant or a movable, or there is a presence of pus, okay? So, and also you have assessed radiographically, okay, where exactly the pus is there. So the patient will be in a severe pain. So better you have to give the local anesthesia. If you don't give the local anesthesia, the patient will jump. So better you give the local anesthesia. That too, if it is a molar, definitely you can give a block. And not only with the block, you have to give some infiltration around the abscess, so that that area is going to get numb. And after that only you have to do the stab incision, or you have to do the negative pressure from the syringe. But still, many patients will have some amount of pain, because definitely the local anesthesia doesn't work in the infection cases. And when you are doing, if you are doing intraorally, well, it will be sterile only, or you can use your chlorhexidine or povidone surface to disinfect the surface. And when you are going to give extraorally, usually the extraoral incision should be avoided because of the scar. So better not to give incision extraorally until and unless if there is multiple facial space involvement or cellulitis or something where there is obstruction of airway because of the severe infection. So that time only we will try to give the incision extraorally. Otherwise, purely we will treat intraorally only. So that's how you have to do. And there is an evidence that in case of periapical abscess without a systemic involvement, the INT along with the retrograde MTA filling is often sufficient for resolution, reducing the resilience of systemic antibiotics. So if you have without this, again, systematic and the antibiotics, again, until and unless fever, and that according to American Endodontic Association, they say that they have some guidelines when to give the antibiotics and all. But Preferably in cases of abscess, it's better to give antibiotic, that to broad spectrum antibiotics. So this is just a video showing like how the intraoral sinus can be treated. So here there was an active intraoral sinus which I just removed the part, and then you can see that in the picture in the video 2, you can see that whenever I'm irrigating solution is getting out of the sinus. So this is a clear indication that this kind of cleaning is efficiently will heal 100%. It will heal in no time. Okay, within a span of 1 or 2 weeks, it completely heals. It doesn't take much time. So now let's go to the next part, that is the periapical abscess with intraoral and extraoral swelling. So here, in this situation, again, we have to check with our clinical expertise as well as IOPA and CBCT sometime. And if there is any sinus present, then GP tracing need to be done. And if there is no sinus present, if there is a frank caries, it's well and good that that's the tooth which is causing intraoral and extraoral swelling. But if the tooth is doesn't have any frank caries, then you need to do the vitality test, palpation, and percussion will help you to identify which particular tooth is involved. Again, the first you need to treat here, you need to treat in 3 phases. That is, first is the tooth. Whichever the tooth is involved, you have to treat that with open up, clean up the entire root canal system, and then treat the intraoral. Extraoral swelling, it will reduce by itself. So you treat intraorally by giving incision or draining, and also followed by, if there is negative pressure, if you can do it, well and good, you can do that. And then do the if the lesion is too huge, you need to give the stab incision and make sure you enter into the swelling, and then you need to cure it a little bit. So you are going to break the epithelium. There will be a lot of locules present inside the in the swelling. So you need to break that so that there will be faster healing. So that's how you have to do. The extraoral incision is the last option. If the swelling is not subsiding after your antibiotics and everything, if there is any complication happening, then only you have to go for extraoral incision. Otherwise, we have to manage with the intraoral incision. Then what type of irrigation and intracanal medicament need to be given? In such cases, first and foremost, if there is an active pus discharge through the canal, so it has to be kept open by giving 2% of chlorhexidine, and low percent of sodium hypochlorite can be used. Then in later appointments, you can see if there is no active pus discharge, you can give a combination of calcium hydroxide and chlorhexidine. Then, of course, here we have to give the systemic antibiotics, especially the broad spectrum antibiotics, and then you have to follow. You have to give the analgesics, and the patient will be monitored closely for a span of 14 to 21 days. If symptoms subsides, then only we are go ahead with the obturation. So this is a case of both intraoral and extraoral. As you can see here in figure 1, you have this is a fractured, and the palatal cusp is fractured, and the tooth has become non-vital. And there is some amount of cervical caries also in this case. And she presented with a huge both intraoral and the extraoral swelling. So I had treated it completely with the intraoral approach. So over a period of time, it subsided. So as you can see, there is an intraoral swelling here. So here I have done the stab incision little bit of, and wherever the dependent area was there, as seen in the figure 1. And then you can see how I am doing the negative pressure in the figure 2. So I'm showing you the video how to do the negative pressure. So this is what we call it as negative pressure through syringe. So we go insert well into the swelling, and we are trying to suck back the through syringe.
Hello everyone, and ma'am is facing some technical issue and she got disconnected. She will join us in any moment. I request all the participants, if you have any question related to this topic, you can put it in a comment box. Once ma'am join this show, she will answer all the questions one by one. So she is taking the very good lecture on this very important topic. I hope that it will be very much impactful to all the audience who are watching out there. And she got some technical problem. She was presenting the screen, she got disconnected. So I request you all to be here patiently. Ma'am will join this show and answer the all the doubts related to this topic. Once again, I request all the participants, if you have any question related to this topic, you can put it in a comment box. Once ma'am joins, she will answer all the questions one by one.
Yeah. Hello.
Yeah, you can share the screen, ma'am, like yours
Okay.
from there, start presenting.
Mm, mm, mm. Now what is seen now?
Yes, ma'am, it's visible. You can proceed. You
Okay.
can
Okay.
open the PowerPoint. Yes.
Okay. It's seen now.
Yeah, visible. You can.
Okay. 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 So as you can see here, there is a pus with a negative syringe technique. You can draw the pus and release the pressure from the abscess. So next is the periapical abscess with extraoral swelling only. Now here the patient will have evident extraoral swelling without significant intraoral involvement. So suggesting the infection has spread to the facial spaces. Now here on clinical examination, again, that IOPA and CBCT also you can see if you can identify a particular tooth which is involved, then it's much easier for us to treat it. Okay, okay. If it is very like if it is due to trauma if the tooth has become non-vital, then you need to perform the vitality test and the percussion and palpation test to identify the tooth which is involved. Now, if there is an extraoral swelling, as I said, if there is a cellulitis or if there is an airway obstruction happening, then only you have to give the incision, that is a stab incision, usually given with the blade number 11. And you can in the subsequent slide, I'll show you how the tube is placed so that there is active draining happening. But this is a last option. In an emergency cases only we will attempt. Otherwise, we will try to resolve this in a conservative way. So if the tooth is the tooth which is involved has to undergo root canal, it is initiated, followed by irrigation, thoroughly debridement and removal of all the necrotic tissue, followed by chlorhexidine irrigation, and if there, you can use EDTA and the sodium hypochlorite. This is on the first sitting. In the second, subsequently, here you need to give broad spectrum antibiotics for this case, followed by to relieve the pain, you need to give the analgesics also. And basically, sometimes we have to go for microbiological culture also to know the exact which bacteria is involved to give the systematic antibiotics. But usually the broad spectrum antibiotics, if you give, it will work. So it takes around 7 days to resolve completely the swelling. And later you can go ahead and give the calcium hydroxide once when we have to give the calcium hydroxide as an intracanal medicament is when there is complete resolvement of your extraoral swelling, and you have a clean, if there is no pus discharge and you have a clean canals, you give a calcium hydroxide so that if there is any periapical lesion is there, it is going to heal. So usually it is done after 7 days. Then again, you can wait for 14 days and then you can go ahead with your obturation based on the clinical signs and symptoms, clinical as well as radiographic signs and symptoms. So this is a case purely extraoral. So you can see here there is just a very faint periapical lesion. You can't appreciate well, but she presented with a huge extraoral swelling with a lot of pain and tenderness on this particular tooth. So as you can see here, it is a carious tooth. So once it was thoroughly cleaned, you can see here the canals are clean and with just chlorhexidine irrigation. So there was no active pus discharge through the canal. So it is just purely extraoral swelling, and as well as the intraorally also there was not evident swelling, so I couldn't do any incision or drainage here. So I had to purely depend on the antibiotic and whatever the irrigating solution. So that's what the chlorhexidine works wonder, and followed by a chlorhexidine based mouthwash you have to give. And here in the first setting, loosely bound cotton and thin layer of temporary was given so that there won't be further food lodgement occurring. Then over a period of time, this is a post-obturation. So it took around 14 days to completely resolve the swelling. So after 14 days, I had to obturate this tooth. And this is what the pre-op and the post-op of the swelling, which is resolved after 14 days. So this is a small boy because of the infected tooth, the primary tooth. He presented with a huge swelling. So again, this one, there are two options for this. One is the tooth can be removed, or we can do pulpectomy, followed by chlorhexidine irrigation. Here, I didn't remove the tooth because he was a young boy. So just had to do pulpectomy and gave an open dressing and used copious amount of chlorhexidine irrigating solution as well as mouthwash and antibiotics, systemic antibiotics and analgesics were given to him. So this is how it is. After 1 week or 10 days, the swelling was reduced, and the tooth we had to do the obturation of the tooth. So again, this is a second case where again it's a purely extraoral swelling. The swelling was frankly due to the carious tooth. So once I just opened the axis, there was active draining happening. So we can see in picture 2 that once the chamber was open, the pressure was released, that pus drained through the canal. So this such condition, we call it as active pus draining or active canal draining. So this is after 10 days. So the patient completely, the swelling was resolved, and we did obturation for this after 14 days. So there is another case showing this is intraoral swelling, but through the nose, he presented the pus discharge when we press onto the nose, as you can see in this video, where there is a huge lesion was there. So on pressing around the nostrils, so there was a pus discharge to the canal. So for this, we had to do a surgery. So we had to do a surgical approach. So that's how you can see the Gadapacha, which was exposed here. And 5 and 6, the 5 again, we did episectomy. You can see in picture 6, where we have done the episectomy, then followed by the heated instrument is used to seal the Gadapacha, and followed by MTA placement around the root apex. So this is how it shows in the radiograph. So this is immediate suturing, and 7 days follow-up is your picture 2 and radiograph 3. So there is another case where again, this is it's a typical case, it's a failure case, where the patient had a sinus opening. Okay, usually we see sinus opening in the lower central incisor in the chin area, but this patient presented the sinus opening near the ala of the nose. So you can see here where we have marked here, and there was a huge, this is how the preoperative radiograph showed us. And then when we pressed there was huge pus coming from this sinus. And in the first sitting, what we did was we tried, since there is a drainage here, so here we didn't give open dressing in the first appointment. Rather, we gave a calcium hydroxide dressing, followed by chlorhexidine mouthwash, and also we instructed the patient to press in that area so that whatever the pus need to be discharged. So that's what it is. You can see here. I hope the video will work. No, the video is not working here. So you can see that there is a pus discharge happening here. So whenever we are going to irrigate, even the irrigating solution also used to come through the sinus. So now this is an ongoing case, which we are doing. So this is an intraoral, the same patient, not only the extraoral sinus he had, intraorally also he had swelling like this. So whatever irrigating solution we used to do, basically it never used to come through the intraoral, but extraorally it used to pass through the drainage to the sinus. This is another case showing a non-vital tooth. So there is a big periapical abscess. Again, the patient, it's a kind of phoenix abscess, you can say, or a chronic periapical abscess also you can say, because the patient came only for your there is discolored tooth, or occasionally there is a not that salty discharge. So that's what the patient used to complain. So when we opened it, you can see, you can appreciate here. So on compression, you have this pus discharge. So basically, we have to, the first sitting, we are making sure that whatever the pressure which is created within the tissue, it has to be released. So once it is released, then the healing rate will be faster and patient also will be less pain. So now these are the treatment modalities. So what are the other treatment modalities? That's what I was telling you. If it is an extraoral segments, one is you give an incision and incision or the stab incision you give around the dependent area. The another technique is the syringe technique, which I told, the negative syringe, or it is also called as modified Horn et al. Technique also, wherever the dependent area is there, in that area you just puncture, okay, with a negative pressure, you are going to suck back, okay, and aspirate slowly so that whatever the inside the abscess or the swelling, you need to cure it in that direction only, and as well as you have to do the negative aspirate slowly so that whatever the content which is present in the swelling, it has to be aspirated to the syringe. So this procedure is repeated thrice, and also it reduces the treatment time up to 3 to 4 weeks. So these are the few tailored treatment, and there are evidence showing that if you not only treating only the teeth, if you treat the swelling also along with your antibiotics, basically this is not in the first stage, on the multiple stages, okay, in subsequent appointments, if you give the intracanal medicament with triple antibiotic paste containing like metronidazole, ciprofloxacin, and clindamycin with a ratio of 1:1 ratio, there is definitely reduction in the bacteria and the success rate will increase. So it means that they have seen with subsequent appointments, not only the systemic antibiotics, locally also you need to give some antibiotic paste inside the canal, not into the lesion and all. I'm talking about inside the canal, so that the whatever the remaining bacteria which is present and in and around the periapical region will help in the healing rate is going to improve. So what are the sequelae of periapical abscess? So if there is periapical abscess, if you leave untreated, definitely these are all based on it is not mandatory that if periapical abscess has to go for osteomyelitis or periostitis and all. It again depends on the host response. What is the body's immune response? So based on that, it can lead to osteomyelitis, based on that periostitis, cellulitis, or abscess or midvein angina. So when these two happen, that is cellulitis or Ludwig's angina, then only we have to do it becomes mandatory for us to do extraoral stab incision to release all the complications. So this is one of my favorite case, how people get misdiagnosed, This patient, this is a young boy. With this presentation, I would like to end my today's presentation. Basically, this is a patient, young patient. Initially, he had a pimple on his left side. So he had gone to not dentist, he had gone to a general surgeon. So general surgeon, what he said, okay, there is a pus, okay, fine. What I'll do is I'll curate it and give an incision to that. So he did a curettage for that and gave an incision. You can see the scars here. Okay, then after 6 months, till 6 months, he was fine. After 6 months, there was a pus coming out of it. Then his father, he came to me and he said, Madam, this is how it is. So then when we saw intraorally, in 3/6, there was a root canal treated tooth and also cap was given. So when I took an X-ray, the X-ray seems to be fine. So there was no problem at all. So that's how it was misdiagnosed. But once I removed the crown and then the entire the gutta percha and all, you can see here there is a clear communication. So you can see the pus is discharged when I'm giving the pressure here, and here you can see on the distal canal. So I'm trying to irrigate. So the irrigation is just coming out of through the sinus tract. So it's a clear thing that the tooth, which is the tooth is the main etiological factor to cause the sinus. Okay, so see here you can appreciate well how the irrigating solution is coming out. And when such thing is happening, no, definitely you won't believe the success rate is 100%. Okay, you have to treat the canal well and leave it to it. Definitely everything will be resolved. I'll show you the why it is not moving. Okay. Okay, see, this is after a week. So after 10 days, this is how it represented. Okay, then this is after 2 years. After 2 years, everything is resolved. He was so happy, and seeing him, even that satisfaction, what you get, no, that it's amazing. So this is an radiograph after obturation, and here I didn't give any crown. Okay, we did only a cusp capping by the direct composite. We want to see how effectively it heals up. So this is how this radiograph is after 2 years. So with this, I would conclude that prevention is better than cure. So appropriate treatment planning is completely based on the type of abscess. So incision and drainage is reliable, it is simple and minimal. You should know where to do and how to do. Always is good to have an intraoral approach than the extraoral approach. So make sure the thing should not be complicated. And first and foremost, you need to tell the patient it is not that the one appointment or two appointment case. It is a chronic case. So definitely it will take some time to heal, but always the success rate, if you have done a proper treatment, the success rate is 100%. And definitely this has to be followed with broad spectrum antibiotics, analgesics, and regular follow-up is must. With this, I thank the entire team for giving me this opportunity to present here with you all and share my few experiences. Thank you so much. Thank you.
Thank you so much, ma'am, for your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants on their practice also. We have received some questions. With all your permission, shall we take these questions?
Sure, sure, sure.
The first question is from Dr. Subramaniam. He is asking, how should their choice of antibiotic to be tailored in the cases of penicillin allergy, antibiotic resistance?
Okay, okay. Erythromycin, you can go ahead. Erythromycin, ciprofloxacin, metronidazole.
Okay, thank you so much, ma'am, for answering, ma'am. Like another question from Dr. Anupma, and she's asking what red flags for clinical signals suggest that the dental accesses require urgent interventions.
Dental?
And the question is dental abscesses requires urgent interventions.
Urgent interventions. In cases of dental abscess, they are referring to emergency. If there is a huge abscess involved, let it be intraoral or extraoral. First is emergency access opening. You have to, the tooth which is causing this kind of condition, that has to be root canal treatment, need to be initiated and give an open dressing and followed by your chlorhexidine and antibiotics. Yes, of course, intraoral incision and drainage is must.
Thank you so much, ma'am, for answering the questions, ma'am. One feedback from Dr. Ayush. He's writing wonderful session.
Thank you so much. Thank you so much.
I really hope that they have enjoyed the question like
I
session,
hope
ma'am.
so.
Like as
I
I can
hope
see, there is no
so.
more question. Yeah, there
I
is no
hope so.
more
It will be
question.
helpful for them. Definitely, it will be helpful for all the clinicians over there, like how to treat. This is the day-to-day scenario which everybody faces in their lifetime in the clinical practice. I hope it will be helpful for them and useful for them. Thank you so much.
Welcome, ma'am. It's great honor to have you on our platform, ma'am. We would like to see you in future also with